This presentation is on basal ganglia and the internal capsule. And let's look at what the components of the basal ganglia are. Now, the basal ganglia consists of masses of gray matter which are present in the cerebral cortex, and there are other masses present in the brain stem and other areas of the brain which are related to these masses in the gray matter, but we don't include those in the brain stem as being part of the basal ganglia. Now, the basal ganglia typically consists of two main regions. One is called the caudate nucleus, which is a mass of gray matter present in relation to the lateral ventricle. And we have the second one, which is called the lentiform nucleus. Now, the caudate nucleus and the lentiform nucleus together form what is known as the corpus striatum. Now, the lentiform nucleus, which is present lateral, as you can see here, it's present lateral to the caudate nucleus, consists of two parts. It consists of an area which is present laterally and is darker in color, called the putamen, and a medial area called the globus pallidus, or also known as the pallidum. Now, the caudate nucleus plus the putamen together form an area which is called the striatum or the neostriatum. So we have two terms here. We have corpus striatum, which consists of the caudate nucleus and the lentiform nucleus, and then we have just the striatum, which consists of the caudate nucleus and part of the lentiform, which is the putamen. Now, there are other areas too which are linked to the basal ganglia, and some even include them in the basal ganglia, and this is the one of them is the amygdaloid nucleus, which is present at the tip of the tail of the caudate nucleus. And we have one area called the claustrum, which is an area of gray matter, which you see here, present lateral to the lentiform nucleus. So if this was the lentiform nucleus, lateral to the lentiform nucleus around here is this claustrum. Now, we don't include this claustrum and the amygdaloid nucleus typically in as a component of basal ganglia, because the amygdaloid nucleus usually deals with visceral activity and the function of the claustrum is not known. Now, these three images that you see here are sections taken through parts of the cerebral cortex, showing you different levels at which the caudate and the lentiform and thalamus are cut. And if you see the first one, this is taken from this part here. So here we are looking at the caudate nucleus. This is the thalamus. And here we can see the lentiform nucleus. You can see the putamen and the globus pallidus. The second image is probably taken from an area which also, taken from an area which also includes this amygdaloid nucleus. So we can see the caudate, and it's gone around and come here. So here we have the amygdaloid nucleus also seen in the temporal lobe. And then this is the thalamus, and here we have the lentiform, the putamen and the globus pallidus. Now, this image is taken further anteriorly, where the caudate nucleus and the putamen are joined together, and that's why they're called striatum, because you can see these stria passing through. Now, in between the caudate nucleus, the lentiform nucleus and the thalamus, you have an important area of white matter present, which is known as the internal capsule. And you can see the internal capsule over here. So you can see how it is present between the caudate nucleus and the thalamus medially and the lentiform nucleus laterally. And this internal capsule continues below with the crus cerebri and other parts of the midbrain, and above it continues with a radiating mass of white matter known as the corona radiata. Now, other areas which are related to basal ganglia and influence it are the substantia nigra, which is present in the midbrain, and it's called nigra because it has melanin pigment in it, which gives it a black color. So this is the substantia nigra. And then we also have the red nucleus present in the midbrain, which again influences the basal ganglia and has connections with it, and it's the red nucleus is mainly important for learned motor activity. Now if you look at each of these main components and describe them, the caudate nucleus is a C-shaped mass of gray matter. It has a large head. Then this area is the body of the caudate nucleus, and then this is the tail, which ends in that amygdaloid nucleus, which is present in the temporal lobe. Now you can see here it is related to the floor of the lateral ventricle, so you can see how it forms the floor of the lateral ventricle. The lentiform nucleus, as is apparent here, is wedge-shaped, so you can see it looks like a wedge. And I've already described that it has two parts, a putamen and a globus pallidus. The amygdaloid, of course, is situated in the temporal lobe, and this claustrum lies lateral to the lentiform, and we don't know its function. Let's look at the functions of the basal ganglia, and typically the functions can be described as the basal ganglia both promote and inhibit motor activity. What they do is they amplify and facilitate those processes which contribute towards the preparation and execution of certain desired activity, whereas they inhibit unwanted movements. So they suppress those movements which are not needed when you're performing a desired activity. So apart from this basic function, the other functions of the caudate nucleus are it regulates voluntary movement and learning of motor skills. And how all of these functions are carried out is that the basal ganglia or the striatum, as you can see here, they receive inputs from the cerebral cortex, the motor part of it, also the sensory cortex, the thalamus, and the brainstem. So all these inputs get into the striatum, and from the striatum it passes on to the globus pallidus. Now the globus pallidus is the output. So from the globus pallidus, fibers pass back to those same areas that they got the impulses from in the first place. So you can see how they influence the cortex and the thalamus and brainstem. And then the cerebral cortex and the brainstem and thalamus, they link up to the anterior horn cells and the cranial nerve nuclei. So while the basal ganglia has no direct connections with the spinal cord, because of its influencing these areas which influence the spinal cord, it therefore ends up influencing the cranial nerve nuclei and the anterior horn cells, much like the cerebellum did to a certain extent. Now the basal ganglia are also important in regulating postural reflexes and maintaining posture, and we will see that when there is a problem with the basal ganglia, sometimes posture cannot be maintained. As I mentioned earlier, it's important for the execution and planning of certain desired movements, and while this is being done, it prevents unwanted movements. The basal ganglia also are important for lending expression, motor expression to emotions, just like you smile when you hear a joke, or you gesticulate when you're describing something, or you get all animated. So this kind of motor expression which is lent to emotions you don't realize you're doing that, but this is a feature of the basal ganglia. And in fact, when the basal ganglia are damaged, then this kind of motor expression is gone. So people will not smile if they have a damage in the basal ganglia. They will not smile when you tell them a joke, but you ask them to smile voluntarily, they will do so. Similarly, they will lose all these gesticulating movements, when telling a joke or when they are kind of describing something, because the basal ganglia is not acting at that time. The basal ganglia is also important for performance of certain stereotyped muscular activity, and the most common example we give is that swinging your arms when you're walking. And again, when the basal ganglia is damaged, then this movement goes. So the people walk with their hands by their sides. Let's look at some clinical correlations here, and we'll begin with Parkinson's disease, which is also known as shaking palsy, because the patient has tremors which are seen at rest. Now compare this to cerebellar disease, where you have tremors only when a person performs a certain action, but at rest there are no tremors. In Parkinson's, on the other hand, we have tremors at rest, and this stops when the patient attempts to do a particular movement. Hence, they stop these tremors usually by moving their fingers all the time, and that is known as pill rolling. Another thing that is noticed in Parkinson's disease is that there is a rigidity in both extensors and flexor muscles, and this rigidity continues throughout the movement. Therefore, it's known as a lead pipe type of rigidity. Unlike the one that you see where there is a clasp knife type of rigidity where suddenly the muscle gives way. In this, the muscle remains stiff all throughout. Bradykinesia or akinesia is something that's seen in Parkinson's disease, where there is a lack of expression. And if you remember, one of the actions of basal ganglia were to cause motor activity during any emotions. But in this, there is lack of expression, so the person has a mask-like face. They also do not have for example, when they walk, their arms do not move along with their walking. So that, remember, that was a stereotype motor activity. Now that is absent in such people. And you'll notice that these people have a shuffling gait and a stooped posture. And they walk with small steps, and you can see here the person is walking with small short steps, and they tend to kind of lean forwards. And because they cannot maintain their posture, if you push them slightly, they tend to fall over. Normally, when you push a normal person, if they're stooping, they can maintain their posture and they do not keel over. Now, Parkinson's disease is seen because there is a problem with the substantia nigra, and so there is a lack of dopamine, and this affects the entire circuit of the basal ganglia. Now, the basal ganglia, they affect the motor cortex, the sensory cortex, and the brainstem. In a very fine-tuned manner. So they have their inhibitory effect, and the facilitation that they carry out is extremely fine-tuned. So if anywhere along the pathway, if something goes wrong, you either have an excess of the inhibitory effect or you have an excess of the facilitation. So you will see the effect as either, the person is totally mask-like, or, for example, in the other conditions that we'll be seeing, that you have excessive uncontrolled movements which are seen. Let's move on to the next clinical picture that we have, and we have a few over here. The first is known as Huntington's disease, and in Huntington's disease, what we notice is that the person has something known as coriform movements. Now, these are involuntary movements that you see, and these are repetitive, jerky, and they're purposeless movements. And I'll show you a video where you will see these kind of movements being performed. Now, Huntington's disease is a hereditary disease and is seen because of a problem on chromosome 4. Sydenham's chorea is a different type of chorea. The movements are exactly like you see in Huntington's, the difference being that the cause is because of rheumatic fever. And it is felt that in rheumatic fever, the Streptococcus bacillus, what it does is there are certain proteins present which are similar to the membranes of the neurons in the basal ganglia. And the antibodies of the host combine with not only the bacterial antigens but they also attack the membranes of the neurons of the basal ganglia, and hence it's a sort of autoimmune disease. Hemibilismus, as the name suggests, it's hemi, so it's a kind of abnormal movements that you see, but this affects only one side of the body, and usually the subthalamic nucleus is the one that is affected, and this subthalamic nucleus prevents unwanted movements. So if that is affected, you will see these unwanted movements which affect one side of the body. Ascetosis is a condition which is seen in this child over here, where you see sinuous writhing movements, and they usually tend to affect the distal segments of the limb, and these are very slow and sinuous, unlike the others which are quick and jerky. Now I'd like to show you some videos of some of these conditions, and let's begin with the first one, which is showing you Parkinson's disease.
Parkinsonism is a symptom complex composed of 4 different cardinal sets of signs and symptoms. The first of these is tremor. Tremor is an abnormal involuntary movement which consists of alternating rhythmic involvement of the agonist and antagonist at any one joint. This gentleman demonstrates tremor of both upper extremities, both lower extremities, and his jaw. The tremor of Parkinsonism is characteristically present at rest and ameliorated, at least in part, by the initiation of purposeful movement. Although tremor is perhaps the best known of the signs and symptoms of Parkinsonism, it is not invariably present. The presence, however, of a rest tremor like this is pathognomonic of Parkinsonism. Here we see the tremor of both hands ameliorated by the initiation of purposeful movement, and the recurrence of the tremor after the hands rest on the knees. This is the classic rest tremor of Parkinsonism. Throughout these hand motions, the tremor of the jaw persists. Again, we see purposeful movement ameliorating the tremor in the hands, while the jaw tremor persists and the hand tremor returns following the purposeful movement. Second of the cardinal signs and symptoms of Parkinsonism. Akinesia refers to difficulty in initiating and carrying out purposeful movements. The term bradykinesia or hyperkinesia are also used, but are really synonymous with akinesia. Here we have the same gentleman having difficulty initiating standing from a seating position. Now the gentleman is seated in a chair that is higher and is easier for a Parkinson patient to get out of. The same patient with his rest tremor initiating gait. Steps are small, shuffling. Turning is accomplished with many small steps. Again initiates movements with slow, small steps. There's also a lack of swinging of the arms, what is known as decreased associated movements during walking. Again, the small shuffling steps of a Parkinson patient. When Parkinson patients are asked to step over lines, however, they can walk with a fairly normal gait. And again, we see the normal gait there and the small shuffling steps when he walks without the guidance of lines. And turning with many small steps and a lack of another manifestation of the akinesia of Parkinsonism is the masking none of the normal play of expression that we see in a normal face. He also tends to stare without blinking, a phenomenon known as a reptilian stare.
Now let's look at Huntington's disease.
We now use the term chorea, however, to define a class of abnormal involuntary movements. Choreic or choreatic movements consist of individual, brief, purposeless, non-repetitive jerks of individual muscles. These tend to be rhythmic and non-patterned, but they appear in series or groups, which result in rather complex movements. The movements are made more complex by the patient's attempts to mask them by purposeful movements. Here we have a patient with fairly severe choreatic movements involving various parts of her entire body. Here we see movements involving the jaw, the tongue, the mouth, the neck. Each is an individual, brief, sudden, purposeless journey. In this individual, the choreatic movements are due to Huntington's chorea. The individual movements, however, look the same no matter what the etiology of the choreatic disease.
Let's look at hemibilismus.
Describe another form of abnormal movements. The movements of hemibilismus involve the arm and leg on one side and are usually contorting and continuous and of a rotatory nature. Hemibilismus also merges with hemichorea. The abnormal involuntary movements of hemibilismus usually come about as a result of a CVA. The lesion usually involves the subthalamic nucleus or corpus luisi, but can also involve the globus pallidus or the connections between the globus pallidus and the subthalamic nucleus. Here we have a patient with relatively continuous, severe contorting movements of his right side, involving the arm not quite as much as they do the leg. We see the continuing rotatory movements of his right leg.
Let's move on now to the next slide, and this is of the internal capsule. Now, the internal capsule is an important part of the nervous system, and it lies between the thalamus, the caudate nucleus, and the lentiform nucleus. So we have the lentiform nucleus lateral to the internal capsule, the caudate and the thalamus medial to the internal capsule. It consists of fibers which run from the thalamus towards the cortex, so these would be ascending fibers, and it consists of fibers which run from the cortex to the thalamus, down to the brainstem and down to the spinal cord, so descending tracts. So it has both ascending and descending tracts. And if you look here at this picture, you can find that this is the part of the midbrain called the crus cerebri, where the descending tracts are present, and posterior to this you would have ascending tracts which were traveling all the way from the spinal cord. Now all of these tracts have to pass in this narrow space between these three nuclear masses. So that is the area. This part here is where you have the internal capsule being present. Once they maneuver through this narrow space, then they project to the various parts of the cortex. So this is how you can see it's a fan-shaped projection, and this area is known as the corona radiata. It looks like a crown which is radiating, hence it's known as the corona radiata. Now let's look at the parts of the internal capsule. As this internal capsule passes between these three nuclear masses, it has a V-shaped passage. And so we have a part which is present between the lentiform nucleus and the caudate nucleus. So this area here, and this area is known as the anterior limb of the internal capsule, and this is where we see the anterior limb of the internal capsule. Then we have a central portion which forms a curve in this fashion, and that is known as the genu of the internal capsule because it looks like a pointed knee. So a genu means knee. So this area is called the genu of the internal capsule, and you can see this approximately here is where the genu of the internal capsule would be. Then we have a part of the internal capsule which lies between the thalamus and the lentiform nucleus, and that is known as the posterior limb of the internal capsule. So here's where the posterior limb of the internal capsule is. And lastly, we have a part of the internal capsule which has fibers which cross behind the lentiform nucleus. So this is how they are crossing behind, and they are going towards the occipital cortex and form the optic radiation, which you already did. So this is known as the retrolentiform part of the internal capsule, also called, because it's going behind the putamen, so retroputamen part of the internal capsule. Now, if you look at the internal capsule, you will see the important tracks that we need to know of is that related to the genu, we have the corticonuclear fibers. So these are the fibers which are going to the cranial nerve nuclei. And in the posterior limb, we have the corticospinal fibers. So these are the descending tracks and the areas where they are present. Now, in the posterior limb, we also have the sensory fibers which are ascending to the parietal lobe of the cerebral cortex. So these are and they are going from the thalamus. If you remember, the thalamus was the sensory relay station, and then from the thalamus, the fibers went to the sensory cortex. So they also are lying in the posterior limb of the internal capsule. In the anterior limb of the internal capsule, we have other thalamocortical fibers which are going, and we have the corticopontine fibers. If you remember, these corticopontine fibers went from the cortex to the pons, and then from the pons to the cerebellum. So these are the corticopontine fibers related to the anterior limb. The blood supply of the internal capsule is extremely important, because if there is a problem in the internal capsule, depending on the area which is involved, we will show neurological deficit in those areas. Now, the internal capsule is supplied by the internal carotid artery. It's supplied by a branch of the internal carotid artery, which is known as the anterior choroidal branch, which is this one. And here's where we see this anterior choroidal branch. And if you look, you can see it is supplying the posterior limb of the internal capsule. Then we have medial striate arteries. The medial striate arteries, which supply predominantly the anterior limb of the internal capsule, with the anterior choroidal was supplying the posterior limb. And then we have very important branches which come from the middle cerebral, known as the lateral striate branches. So we have these lateral striate branches here which come from the middle cerebral, and you can see it here. Now, these lateral striate branches, as you can see, they pass through this lentiform nucleus and come to supply quite a bit of the internal capsule, the genu part of the anterior limb and the posterior limb. And of these lateral striate branches, we have one particular artery called the Charcot's artery, which is extremely important because this is the one which is most prone to cerebral hemorrhage. It has a very tortuous route passing through this lentiform nucleus, and hence this is the area which commonly, if a person has hypertension, the artery ruptures at this point. Now, if any of these branches, or the Charcot's artery, any of these lateral striate or this named lateral striate artery called the Charcot's artery, if they rupture, usually you will find that the lower part of the anterior limb, the genu, and the posterior limb get involved, and that leads to neurological deficits on the contralateral side. And when an area of the internal capsule is damaged, because the fibers are so concentrated, so it may even be just a small area that is affected, but the effect seen is over a larger part of the body. And hence, whenever you have hemiplegia, most often the damage is in the internal capsule, because in the cerebral cortex, it means the entire part of the gyrus has to be affected, and that is rather rare. So usually when one has hemiplegia or there is a large neurological deficit, the damage is most often in the region of the internal capsule. Now that finishes this presentation. So make sure you look at this presentation more than once, especially those videos which show you the conditions, so that you understand them